Yeah.
Okay.
Very live.
Yeah.
Very much indeed. Right, good morning, everybody, and a very good welcome to this rather delayed meeting of the Shropshire Health and Wellbeing Board. You will all understand that due to the general election, an awful lot of important committees wait until after the general election until they could be held. So just to remind you that this meeting is being live streamed and recorded, and members of the public will be able to see the meeting and hear the audio. Right, can we go round the room of attendees, please? We'll start with me. I'm Councillor Cecilia Mockley. I'm the portfolio holder for adult social care and public health at Shropshire Council.
Hello, I'm Penny Basin, Head of Joint Partnerships, a joint role, Shropshire Health and Wellbeing ICB and Shropshire Council.
Good morning, I'm Claire Parker, Director of Strategy and Development at Shropshire Health and Wellbeing ICB.
Good morning, my name's Nigel Lee. I have a dual role. I'm the Director of Strategy and Partnerships at Shrewsbury and Telford Hospital, and also the Chief Strategy Officer for NHS Shropshire Health and Wellbeing in the ICB.
Right. Let's go around.
Shelley Davis, Committee Officer.
Louisa James, Business Support Partnerships.
Rachel Robinson, Exec Director for Health, Wellbeing and Prevention at Director of Public Health.
Right, so we've actually got more outside the room than we have inside the room. However, it's very pleased to welcome those of you who are online. So can we start with David, please?
Morning, it's David Crosby, Chief Officer for Partners in Care.
Thank you. And then moving on to
Ben Hollands.
Ben, please.
Yeah, good morning. So Ben Hollands, Midlands Partnership Foundation Trust. I'm the Health and Wellbeing Strategy Implementation Manager there.
Thank you, Nicola.
Good morning. I'm the Associate Director of Primary Care for the ICB, Nicola Williams.
Great. Jeff?
Morning, Councillor Jeff Elner, Shropshire Councillor, Chair of Health Overview and Scrutiny Committee.
Welcome. Laura?
Morning all, Laura Tyler, Assistant Director for Joint Commissioning, joint role between Shropshire Council and Shropshire and Telford and Wrekin ICB.
Thanks, Laura. Mark?
Good morning, Mark Price here, Area Manager, Shropshire Fire and Rescue Service.
Great. Thank you all very much. So that's you all online. And we have apologies from a number of people. Simon Whitehouse, Chief Executive of the Shropshire Telford and Wrekin ICB Integrated Care Board. Laura Fisher, Head of Housing, Resettlement and Independent Living at Shropshire Council. Patricia Davis, Chief Executive of the Shropshire Community Health Trust. Paula Mawson, Assistant Director, Integration and Healthy Population, Shropshire Council. And Tanya Miles, Executive Director of People at Shropshire Council as well. We think we may have a few more.
Yes. Yeah, I think we have apologies also from Lynn Corley as well.
Yeah. Great, thanks very much. Okay, moving on to item 2, disposable pecuniary interests. Does any member of this committee or anybody online feel that they have any pecuniary interest in any of the items being discussed, which is not already reported in the register of interests? No. Good, thank you very much. Okay, moving to the minutes of the last meeting. On 18th of April 2024, has anybody got any amendments that they would like to make to those minutes, or can I accept them as a correct record? Okay, thank you all very much. Let's accept them then as a correct record. We don't have a public question, so we skip nimbly over that. And we move straight on to our strategic items for discussion. And the first one, for which we have an allowance of 50 minutes, which I suspect we may not need, but it's there if you want it, Penny. The Neighbourhood Working and Local Care, Penny Basin, Head of Joint Partnerships, and Claire Parker, Director of Strategy and Development, NHS Shropshire, Telford and Wrekin, will be taking this. So would you care to kick off, please, Penny?
Oh, thank you. So Claire is going to take, Claire will take the first bit of a presentation prepared, but just to say that in the pack there was a report that we will consider that the group has read, and also a number of presentations that have been presented to the Shropshire Integrated Place Partnership and others for reference as appendices. So thank you, Claire.
Right, thanks.
Thank you, Chair. Thank you, Penny. I think this is probably a really exciting piece of work that we're doing. And I believe this is the first time that it's actually come to the Health and Wellbeing Board. It has been to SHIP, but I think it's a really good opportunity to showcase some of the work that's being done by the integrated teams. So the first slide is just talking about the strategy in general. And we have, you'll remember, through the Integrated Care Partnership, an integrated strategy with some priorities that are made up from clinical priorities, wider determinants of health, and other health inequalities. And these align very closely to the Shropshire Plan, things like access, inequalities, wider inequalities. And that's the focus that we've taken around the neighbourhood working and the integrated neighbourhood approach to align the strategic objectives of both the Shropshire Plan and the integrated strategy.
It's a bit slow. It's a bit sleepy this morning.
Thank you to my glamorous assistant. The other piece of work that was a line that Rachel and Penny led at quite a few months ago now, isn't it? It was around the prevention framework, which was really, really well supported, and that has been discussed at Health and Wellbeing Board. But it's just a reminder that the 4 priorities that came out of that were around access, so 1 point of access. So wherever you access health, prevention, social care, it gets you to the right place. Integration, which we'll talk about in a bit more detail, and Penny will definitely talk about that around our neighbourhood approach. Person-centred care, which absolutely has to be at the heart of this, and what impact we're making on individuals. And then actually vibrant communities, and we're starting to kind of see that through the integrated neighbourhood approach, and that's really quite exciting. We do need to think about our voluntary and community sector. I'm sort of conscious they're not here. I know David's there, but having a sustainable and supported voluntary and community sector is really important, and that is reflected in the integrated strategy, and I know it's reflected in the Shropshire Plan. So the local care programme really talked about out of hospital care, but it started off really from around discharge processes in the virtual ward, which have now kind of become business as usual work. So when we were looking at integrated neighbourhood teams and an integrated neighbourhood approach, this felt very comfortably sitting in the local care programme. And there were 2 elements to it as we've refreshed it and re-looked at it. So one of those is around those neighbourhood teams, those communities working against the joint strategic needs assessments in the places and what they look like. And then the other part of it, the second part of it, is around the design of those integrated pathways, particularly NHS to NHS, but making sure that all of those other services are wrapped around those integrated pathways. And we're talking much more here about prevention, integration of community and primary care services, and how we work and strengthen those so that our population don't always have to go to the acute, that actually they can be supported before they're unwell, keep them well, and then support them while they're dealing with long-term conditions and that sort of thing. So that's going to be the purpose of the local care programme going forward. And then the final, I hope this is the final slide for me, I think, isn't it? So one of the pieces of work that we've linked up to are the children and family hubs and the work that's been going on. I think the credit to Shropshire Council and NHS colleagues, plus voluntary sector as well, other partners, is how we've actually looked at linking all of this work together. So the women's health hubs, the family and children's hubs, the work around the neighbourhood approach has been pulled together rather than being done in splendid isolation, and thinking about how do we make those links? How do we make sure that we're not duplicating work? How do we identify where we've got any gaps? And so those conversations started very, very early on, and has helped us develop that kind of neighbourhood approach. So I'll just hand over to Penny, and then she'll just take us through the detail of that.
Thank you very much, Claire.
Thanks. Yeah, and so just to say, I'll come back to this slide in a second, but just building on what Claire said. So building on what Claire said, I think that the alignment of our strategic approach. So if you look at the integrated care strategy alongside the Shropshire plan, alongside our prevention framework, you start to see a real alignment of understanding that in Shropshire in particular, given the sparsity, given the size of the county, and given the needs of our population, that we really need to do something different to reach out to our communities. And going back to the priorities of the prevention framework, it's about access. How can we work better together using our resources in a more efficient way in order for people in local areas to connect with services? And actually more than that, how do people sort of create their own health and well-being, connecting with the voluntary and community sector, and how do we collectively as a system make the most of that, but actually work really closely together on that? So our approach, our neighbourhood approach, and these slides, there's a few slides intermingled that are system slides that cross Shropshire, Telford and Wrekin, but also really focus on that alignment with the work in Shropshire in particular. And so our neighbourhood approach is about joining up local services in the community and fostering those community connections so everyone can thrive. Now, that's our system approach, and you'll see in another slide coming up that we have a more nuanced approach, a nuanced sort of strapline for Shropshire, but really what we want is the same thing: thriving communities. People recognise that their own skills, abilities, their people themselves are assets. We are doing better at using our resources to best effect, really taking the preventative approach around that. So that's the kind of what we want to do and what the approach is around that neighbourhood working. For a number of, in fact, 18 months to 2 years now, we've worked on this model. So we've been working collectively with our colleagues in health around that person-centred approach. People are at the heart. This is an all-age approach, but actually the start of this work came from the early help system guides. So that work on children, young people and families. And so from a national perspective, that system guide focuses on younger people and families, but we can recognise that actually this applies across all our ages in Shropshire. And in particular, we have an ageing population here, so we need to think very carefully around that whole all age approach. The people are at the centre, and actually as services, we have a role in ensuring that those things around people are of best quality they can, around infrastructure, around how do people live well in their communities themselves, but also in the services we deliver in that blue section that we could do better to integrate. And so that, as Claire said, wherever people access their service, the people they're accessing something from have a how can we help approach, and recognise that it might not be their service that can have the answers, but they are really well connected to the services that can, and that we do much better at making sure that people get access to what they need at the point of entry, and that their focus is on how people support themselves. And then the outer ring is really around, we know people will need secondary care services, they will need crisis services at some point in their lives. And so when those pathways to those services are easy to access and of good quality when people get there. As I said, that our strap line very locally for Shropshire, which aligns very well to the Shropshire, Telford and Wrekin neighbourhood approach, is around supporting people to live their best lives and centres around making it as easy as possible for people to stay happy, healthy and connected in their community. And that is our One Shropshire vision. How can we do that working together? Our commitments for prevention and integration, again, we've spent a long time working together to create these, and we've talked about them a lot. So I won't go through them in great detail, but it's around that proactive work. So actually recognising where people, we can ask people how they, how and what they need, and make sure that they get it and are able to support themselves. We can take that real proactive, person-centred approach, working with the communities in that preventative way across services, as we already talked about, with that doing what evidence says works, and also understanding our communities. So what is it that the individual communities in our large area really need? And that test, we have been taking very much a test and learn approach, which is really about being given permission and that growing the work from the ground up with colleagues at the coalface. These commitments align very well with the development of the neighbourhood working integrated neighbourhood team approach of the ICB and across that system. So again, we're kind of intermingling here our thinking and our strategy with what's happening at system, with what's happening locally. But it's very much about improving outcomes for children and young people and families, promoting that early diagnosis, supporting people of all ages with self-care, managing long-term conditions, as Claire talked about previously, implementing that person-centred approach, greater emphasis on social prescribing. Now, we have a specific social prescribing programme, but social prescribing happens organically across our communities. How are we making better use of that is as part of our approach, and ensuring people can access the right care at the right time. So of course, people need care at some stage. How is it easy to access and of good quality? So I think there's, yes. Team of teams. So one of our strap lines as well with this work is creating multidisciplinary teams in communities. And I'll talk in just a minute about the work that's been going on around children, young people and families. But it's really important to make the distinction between, it's not a new team, it's a team of teams. So there's a multidisciplinary approach happening where you bring together a whole host of professions and of people who can help those in communities. So thinking about the voluntary and community sector, our early help teams, social prescribing, primary care, social care, adult and children's social care, district nursing, they all are part of this approach going forward, and bringing the teams together to work collaboratively to create a team in an area. It's not, and I think colleagues are keen that we make that distinction. It's not a new team where others might think, oh, we'll just give it to that team and they'll sort it out. It isn't. It's around that team coming together and working really collaboratively with the lead taking, the right lead taking an approach for an individual or for a family or child. So we've been, as I've alluded to already, we've been working on building that integrated multi-agency team in Shropshire for about 18 months to 2 years. And it's really been working from the ground up again, and that is bringing together a whole host of partners in that team of team approach. What happens currently, and it's the cornerstone really to developing the community and family hubs, is that those teams get together in all the corners of the county and they bring together families and children that they are concerned about, that they feel need an integrated approach. And so far, those teams have worked with 109 families and who have 260 children. All of those families have an action plan as part of that work, and they all include multi-agency working. The risks associated with those families are 74% are known to have mental health concerns, 64% at risk of escalation. So this work is holding a lot of families at risk of needing more, higher level of care, and actually into social care or targeted early help. And so the work is so important to keep those families and those children from escalating. Sometimes they do need escalating because that is the right thing. And the work is the consultation panel, as they've been called, and the multi-agency team is able to make that risk, that assessment, and escalate appropriately. But in effect, the point is to keep people from needing escalation. 61% of those children are at risk of child sexual exploitation. 43% of the children are at risk of permanent exclusion from school. And that's a really important one, because that's one of our key outcome measures that we're going to be working on. I mean, they're all outcome measures, but that is actually keeping children in school. We know that has huge implications for a child for the rest of their life, and for that family. We want those children in school. And we know we're working on the data. It's early days. but we know we've had significant impact on keeping children in school and getting children back into school through this work. Really fantastic work that's been done through that multi-agency approach. So building on this, we are developing community and family hubs. I think the vision around that is that those teams have somewhere, a hub in a community where when those teams aren't meeting as a group to look at families in particular, but they do have somewhere to drop in and hot desk where they can and connect with each other. So they will continue the integration work and the early help work for children, young people and families. Our community health trust are also building drop-ins for adults, and we also have drop-ins for children, for health visitors. So those are active now across the county, where parents are able to bring 0 to 5s to talk about all kinds of things: baby weighing, weaning, any concerns that parents have. They're able to come, and those are all publicised now on our family information service and through the community trust. So the proactive care work is around adult multidisciplinary working, very similar to what we've done with children and young people, but that is around looking at those people most at risk of crisis, and actually, rather than letting people go into crisis, working with them early on and seeing how we can support them earlier. That is getting going in the southwest of the county and will be housed in the same place that we've got our community and family hub in Ludlow, so in the youth centre in Ludlow. Part of this work, a core element that's really developing, it has a national imperative, but it's great because it seamlessly aligns with this into women's health and wellbeing hubs. So we will have up and running next week in Highley our first women's health and wellbeing hub, where we're going to have additional sexual health services along with which will be happening at the same time as our baby weighing, our health visiting clinic, which will be happening, which is also sort of leaning into and developing this month menopause support as well. So that's the sort of test and learn approach, and we will be developing, working closely with primary care networks on that health and wellbeing, or the women's health and wellbeing hub from there. And that is cross Shropshire, Telford and Wrekin. So again, it's just multidisciplinary teams working with adult social care transformation on the front door, working also from a Shropshire Council perspective with library transformation. So libraries are already hubs. So rather than creating new hubs, how can we work with our libraries on the hubs holistically? What a fantastic place for people to get the support they need when they can also self-help through all the resources that you've got at a library. And then from a Shropshire Council perspective, people who need access to badges, as in the blue badges or whatever, that they're able to do that there, and council tax support and understanding that will happen at the same place. So we have some examples of this work already happening, and actually we're not taking credit for this whatsoever. We have a fantastic community hub in Mayfair Centre in Church Stretton, which has been going for many years, and it is run by the community for the community. But this is what we aspire to be, really. They have 82 services and 280 volunteers working at the Mayfair Centre. What a fantastic place. It has support for all ages. People in that community know that if you need to know something, if you need a bit of help, if your parent needs help, or you need a little bit of something, that's the place to go, and it's connected to services. So it's for us, this is our kind of how can we remodel that elsewhere in the county. So we are trying. I'm not sure we'll get there ever, but the Southwest hub model and integrated teams. So very much the Southwest primary care network is driving this forward in Ludlow and Bishop's Castle in particular, but we'll be looking at spokes in the area as well. Family hub in Ludlow, Bishop's Castle working with the reopening of the hospital and thinking about how are we putting drop-in clinics there, how are we supporting that area, and obviously Church Stretton working with Church Stretton and the Mayfair Centre. And then there's a list of those involved. A core to this work in the southwest of Shropshire, as I've already mentioned, is the proactive care. So that is working with people with moderate frailty, 2 or 3 long-term conditions, coordinated approach, working holistically with person-centred approach across organisations, and the primary care coordinator employed by the primary care network is core to that work, as is the data, so using that risk stratification. The Highley Health and Wellbeing Centre is another fantastic one that has opened in Highley, but this is also gives us extra space to be able to put on the Women's Health Hub and health and wellbeing hub as an example, but it's also an area that of known deprivation and at the highest risk of the cost of living crisis in Highley, and it's also a very isolated community. So for our point of view, it's fantastic that we're able to use the leisure centre there, the Severn Centre. They've been fantastic partners working with us. The GP practice has moved in there. The library has been retrofitted and is looking fantastic. And the primary care network director, who is there on the screen, has been absolutely the driving force behind the work, and it's amazing. And actually, we were there with meeting the other day, and the children came into the library and were screaming with delight with the what was the new pieces of furniture and the new books and the new there's a new chalkboard and they were playing with it, and it was like it was the prevention at work. It was the most fantastic thing that they were excited with that new space. So there's really fantastic work happening across Shropshire. This slide was just around recognising that a hub isn't always one place, and we're very aware of that, and it is about working collaboratively, connecting, creating that network, and that is all about the work that we're doing. We also recognise that, just go back, that it is more than space and more than few teams. It is about working together and enhancing our skills and being ready and aware and happy around that culture change. And it isn't always easy, because I think as services we get quite fixed on what we deliver and to deliver that of our best ability, and that's understandable. But actually sometimes it makes a lot, it helps a lot when you lift your head up and look across services and think, oh, how can I work with them? What more could we do if we work together with a different organisation? And so our next phase of the work, or part of it, is to develop that kind of new way of working. And our voluntary sector, this is to us fantastic. So the Shropshire Citizens Advice has been leading alongside Shropshire Council and the Food Poverty Alliance around developing new ways of working in the southwest of the county through this Shaping Places work, which was a grant fund that we received a few years ago. They put together this toolkit called Ask, Assist, Act. And it's really a way of working where you start a conversation with someone about their concerns. You share the reliable information and what you know, and you signpost or you connect them to further support if they need it. But by doing this approach, you suddenly have a workforce that's like quadrupled in size, because everybody is able to start that conversation and find out what people need and then connect them to what it is that they need. So we're looking at this approach, and the legacy of that work of Shaping Places will be around creating an offer. It's a training offer, but it's a way of working offer that's really connected to that work, and it will be a fantastic legacy for the Shaping Places work, because this has been this is the reviews of this training and this work that they put together have been fantastic. So we're really excited to be building on that going forward. And then everybody wants to know, well, where are the hubs? So some are at work in progress. We know we've got working in Ludlow, currently at the youth centre. Primary care network are there, Enable are there, the early help are there, and we're building that offer. Bridge North, we're working in the library, we're building what can happen there. Shrewsbury, we're in Sunflower House in the north, and we're working towards a place in South Shrewsbury that is a work in progress. Market Drayton, we're working towards Raven House, which is a council building, but we're looking to see how within that area, how we can connect with people where they already go. So the voluntary sector offer. Whitchurch, we've had a particular issue because there's RAC, the national issue around the building materials that have caused a massive problem in Whitchurch for us. And there's been many hours have gone into finding an alternative there. So that's still a work in progress. And Oswestry, we're working with the library. And our approach to the spokes are that where there's already work happening, such as the Mayfair Centre in Church Stretton, how could we just support that by dipping in and doing something supportive, not taking over, not doing something that that tries to take over what's happening there already, but actually what can we do to support? So an example of that we're working towards is Kynaston Road in North Shrewsbury, which is a community-run facility that they have said to us, oh, we'd love you to come and do a health visiting clinic here. There's lots of families that come here with their children. That's really going to work for us. So we're working towards that starting in September there. So there's a lot of work happening, a lot of integrated work happening. I think that's it. Yes, that is it.
Right. Right. Rachel.
Thank you. I mean, I think I just want to take a minute to pause, I think, and reflect back on some of what we're hearing through the work that's been done, if I can just indulge for a minute. I mean, for me, firstly, a massive thank you to everybody that's been involved in this, because neither of you really said it properly, but the amount of work that's gone in to get these up and running, even within just Highly as one example, but across all of those sites, is phenomenal. The commitment, the culture change, the bringing people together, we cannot underestimate any of that. So I think we need to absolutely, as a board, push our thanks back to everybody for their involvement and recognise everything that people have done. For me, this is taking strategy that we talk about quite a lot, that strategic view of what we want to achieve for our communities, and actually turning it into action. We don't often do that enough. We get criticised about that. I think we need to, and I'll come on to what I think maybe some additional recommendations in a minute. I do think we need to keep reviewing that. But actually, we've put in place, from the Shropshire plan to the integrated partnership plan to our framework, some strategy. This is actually us starting to deliver on it. The other challenge we get a lot is around doing this at scale. We know there's and this is where we start to do it at scale. We've given a pathway to trying to do this at scale, not just in one community, recognising the differences between all of our places, which we're all so passionate about, taking that knowledge base, but then trying to scale that up in a way that is meaningful to communities. So I think that's exactly the phased approach that's been taken here. The alignment word, you said it a few times. I don't think we can underestimate how important that is. We are multiple organisations working in very small communities, particularly I think in a rural county such as Shropshire. So alignment is absolutely critical to get the best out of our resources for our communities, that kind of efficiency, that engagement, all of that. And this is what is happening. So, and I think for us, the ask is, how do we continue to build on that? How do we make sure that everybody who's looking at this now believes in that and starts to bring together and that boulder, that momentum that we've got, we need to build on. But the alignment is absolutely critical. And what you can see is a number of programmes of work that are, in principle, sometimes might be delivering slightly different aspects of outcomes. Actually, there's a real alignment of the outcomes. This is in tackling inequalities. It's tackling rural inequalities. It helps support digital exclusion. It is about prevention, continually, primary, secondary, tertiary prevention, moving back upstream. It's about empowering our population. And it's taken that wider terms approach you mentioned there, and the team of teams. This isn't just NHS, it's not just council staff, this is our police and fire colleagues, this is our voluntary sector at the heart of this. So alignment is absolutely critical. And I think the fact that whilst you rightly said, some of this started with the children and families, but that actually is extending, it's all ages, because we know we've got very vulnerable older communities in Shropshire. That's the beauty of this approach, that absolutely is, and this is just continually building. So I think it's important that we take a moment to see what this actually is and how it's actually implemented. I think for me, there's a couple of things I think we just probably need, if I could suggest some further recommendations, because I think this has got to be at the heart of the programme of this board, which is about delivering health and wellbeing improvements across our communities. Firstly, I think there's something about how I know we share it very strongly through the SHIP. How do we share this more widely with partners, the approach that we're taking, the commitment that we've all made, but the actions and those asks. So I think I know we've had conversations at SHIP, we've had conversations here in the principles. We need to make sure that, I would suggest that we almost go on a bit of a roadshow with it, if that's the right word, to get people engaged. And I think the ask then is for all of our partners as members of this board, all of us, what more can we do to align this approach? So as you said, recently as a council, for example, we've said libraries, how do we align this, maximise this for our communities? What more can we do as a council? There's some bits we're really engaged in, other bits that actually this could spark some ways of working. Our new operating, we're not calling that, the way the council will be in the future has got a strong emphasis on customer. What more do we need to maximise based on need that our communities want? But what I challenge all of us in the room to go back and look at, what more we can do to engage in our programmes. I can see Ben on the screen. We had a really good conversation yesterday around mental health and wellbeing through the HOSC. So again, what more can we do? There's real opportunities there to further align that transformation programme. And the COVID from the Vice Service, we were really aligned. So all of us, I think there's probably an ask for us to go back and come back to this board with what more we can do. The other recommendation or ask I would have is around the MEC, the ask. So ask, assist and act. We talked, one of our priorities in our strategy has always been about how we engage our workforce, how we align, how we maximise. This gives us a really strong framework that means something and has been developed by our communities and our communities that we can all adhere to. As a, you know, for years in the NHS, we talked about MEC, making every contact count. It didn't really, I'll be honest, it was making every appropriate contact count. It wasn't really probably the right phrase, but the ask, assist and act is exactly what we're talking about. It's been developed in Shropshire for Shropshire. So I think there's something about as a board, how can we advocate for that, take that as our workforce programme and roll that out. And I guess the final bit is we probably do need to, I think we need to bring this back in quite quickly. We need to go back to those principles that we agreed to last year in our prevention framework and some of our strategies and do ourselves a sense check of actually how are we delivering against these and where do we need to do more. I think for context as well, I know this is going to go through to our local HOSC as well. So again, that framework, that assurance of the board that we're doing what we need to do and for them to have overview and scrutiny around the work we're doing. But I think there's perhaps something about us bringing it back quite quickly to this board as well and making sure that you're getting the strategic buy-in. I'm sorry, that's probably a lot from me, but I think this is fantastic and this is at the root of so much of what we need to do and starts to shift the dial.
Before I go on to anybody else, there's just one thing that I'd like to drop into this, particularly as a very rural member with a very large rural division and a host of very small settlements. It's absolutely great that this very collaborative working, it's absolutely right. It's absolutely the right way to be going. I'm absolutely convinced about it. What I want to be able to do is I want to be able to ensure that we can communicate this through to those people living in those very remote places. Some of them don't have, first of all, no public transport. Second of all, some of them are very elderly, but could really, really benefit from this kind of an organisation. And one of the things that I think we might have to think about is how we actually communicate this out there, as it were. All our communities, all my communities, have strengths. They really do, because they're the ones who actually keep the show on the road in terms of everybody has got something in terms of they'll have a community building or they'll have an organisation or they'll have something. In my view, those are underutilised for this sort of purpose. And I think it would be a very good thing if we could devise some methodology whereby we could communicate effectively with them to say, look, did you realise that this is sitting in Ludlow, sitting in Church Stretton, for example, in my particular case, because the one thing that worries me is that everybody in Ludlow will know about this, everybody in Church Stretton will get to hear about it. They'll get to hear about it through the schools, if nothing else. But the people living out in the sticks, they're the spokes, aren't they? They are the intended spokes, anyway, as it were, of this approach. Are not going to know about it so much, and they're not going to understand it. However, we have got all sorts of ways that we can communicate with them, because we have our parish councils, we have our village halls, and they are very vibrant organisations. I wouldn't say all the parish councils are entirely vibrant, perhaps, but certainly, you know, we do have methods there which we can use. We have organisations there which we can approach and which we can use to actually just grow the understanding of this whole approach. And I think they would be absolutely delighted. And if we could even do something like considering bringing a service into a village hall for, you know, a clinic a week or something like that, whatever it happens to be, whether it's mothers and children or whether it's elderly people or whatever it happens to be. Maybe as this develops, we can think about doing a bit more actually out there. And then I think that will help the whole communication. It'll help the whole understanding of what we're trying to do more than anything else, actually. So this is fantastic. I mean, it's also what I'm very impressed with is that it's come on so quickly. I mean, I don't know how you've done it really, because I know we started from zero not very long ago, and it's absolutely grown like topsy, and it's just great to think that you've got all these people who actually are not working in little silos anymore, but are actually communicating with each other, and the richness that brings and the experience that brings. It can be nothing but beneficial to everybody. Claire.
Yeah, sorry, I know Laura wants to come in. It has been fantastic, and it is about a will and a way of working, and that's absolutely what we need to build on. I think your points about using the community, the village, the hamlet connections, we need to think outside the box. As you were talking, I was thinking we need to use the WI around some of the women's health, because that's a huge network, certainly across Shropshire. Maybe even trying to get in and talk to WIs about women's health, being a member, as I am. And also, there's been, at the moment, there hasn't been particularly to this, because this is about, as you say, communicating, connecting people and giving them permission to try things differently. Now, that's not going to always be the case, because there will be things that we want to implement, pilot and try, but that willingness to do this amount it's starting to show some outcomes, and we know the proactive care has made an impact on use of acute hospital beds, for example. We also need to improve some of those NHS to NHS integration of services and get some of those foundations right in the delivery of long-term conditions. And then we need to make sure that we're really focusing on that prevention piece through what we've got at the moment. So I wouldn't take any credit for it, but I think the team of teams, we're not doing anything new, we're just linking people up. It might even be passing on a phone number, a connection, a network. It's as simple as that, I think. But Penny and the Jesses and the Charlotte Harts and all the people that have been working in the community through the voluntary sector have been fantastic, and it's just giving them the permission to do it.
Absolutely. Yeah. Thanks, Claire. Nigel.
Did you want to let Laura? Laura kindly has got her hand. Has basically had her hand up.
I'm so sorry, I didn't see it.
That's fine. It's fine. Thanks. So just again, echoing what everybody said in terms of the great work that's done, and just three comments from me is it my challenge, Rachel, your challenge back to us from a commissioner perspective is around what we can do around aligning some of that and making sure that that preventative and that alignment, with our providers are engaged with that. I think there's real opportunity there. So we've started doing part of that, and I'll pick it up as part of the BCF, and you'll see a note made around some of the preventative contracts that we're aligning across health and social care to do that. So that's one area that I think we can do more of. Started that journey, but there's absolutely more that we can do. Just the second point is around we know the challenges, don't we? It's now trying to, what's the impact as a system? Can we really collate what is the impact that it's having? What are the case studies? What are the metrics? And so I think it's really, really important, because, from an Ofsted and from a CQC perspective, when we are challenged, it is constantly, what's the impact? How are you measuring that? So I think that's something we'd like to support the system, you guys and all of us to try and pull some of that together. And then the third bit, I think, probably picks up on your point, actually, Councillor Motley, is around, have we got a comprehensive comms plan that really looks at this? Because, the opportunities from an individual perspective, did you know I attended this session, this centre, and I got help for childcare, or I got, they signposted, what is it from a person's individual perspective when they're attending, or the opportunities for them to attend these sessions that they can get some support and help resolved in, but also from a worker's perspective, our own workforce, which is vast, isn't it, across all our areas. What is it that these services can do to support, so that you've got that two-pronged attack? So I wonder, is there a comprehensive comms plan that surrounds this area of work? Because it's absolutely fantastic, and there's real opportunity for us to really sell that and upscale that more than so as long as people are aware of it and know about it. So I know we're on that journey, but I just wondered, is that part of it, and is that something again that we as a system can support with? Thank you.
Yes, thanks very much, Penny, too.
Yeah, thanks, Laura. And it's a really good point. So we have started that work, and some of the slides that you saw today were the beginning of that, where we've got that system approach around how we're communicating it, how that is, so that from a kind of a particularly thinking about our colleagues in healthcare that deliver across the whole of Shropshire, Telford and Wrekin, that the language is the same and that it's understood what it is. So that has started from the developing of the language. We've also got a comms and engagement group that started with the ICB, and we're expanding it now to include our other colleagues in Shropcom and others to bring together that system approach to looking at it. So what we're trying to do is create that kind of what's happening at system, how do we articulate this at system level, and then being able to then drop down and say, actually for Ludlow, this is what our neighbourhood working is this, and in Ludlow, this is how it's being delivered, and in Bridge North, this is how it's being delivered, in Oswestry, this is how it's being delivered. So the work is underway, but hasn't come about completely yet, but it will be through our internal comms as a starting point, and then looking to our external comms as well. So it has started, but I think, if there's anyone from an adult social care point of view that you would like included in, I mean, Maria's was Bridie, but Maria will be involved, but if there's anyone else, I'm happy to make those connections.
Thank you. Nigel.
Thank you, Chair. Probably going to, colleagues have covered a number of the points I was going to make, but I will just, again, repeat some of the points that Rachel made. I think it's really, really important, especially as a strategic board, linking with what we're trying to do from an ICB perspective, to keep checking back with ourselves that what we're saying in our integrated care strategy, which is our whole system across Shropshire, Telford and Wrekin, and then epitomised in the joint forward plan, we'll talk about that later, is then built from work in the communities and the systems and the information and the evidence that we've got, joint strategic needs assessment, challenges that children and young people, families are seeing. So to make sure that from the bottom up, from the top down, whichever metaphor you want to use, things are joining up. And I think those golden threads are really, really important. The second bit is obviously, as we know, and you said at the outset, Chair, about obviously with the election, so some initial outputs. I'm not sure there's necessarily a huge amount written yet from our new Secretary of State for Health and Social Care, but three themes that he's certainly been pushing are around the focus on community and primary care and that work in the communities. So I think that's a good tick. Sure. The second one is a focus on prevention, again, which we described. And then the third bit about the underpinning focus on data and digital technology, which again is something that we need to keep that weather eye on. But I think those first two really, really sit nicely. So I'm really quite confident that this will align with also any changes, if there are indeed any. A couple more very quick bits. From an NHS point of view, there has been some work that colleagues in the ICB have been doing across the NHS system, looking at infrastructure estates, and there's a strategy document coming to the ICB at the next board. Whilst that is NHS, it's a big document with everything from primary care to community to others. So it gives us a good fresh look at a range of different estates. And so the point we were talking about understanding what opportunities there are, at least this gives us a good idea. And the work that we're then doing, Angela, who's the Director of Finance, is the lead on the state side. She's very keen to make sure that we align the priorities, especially the 10-year capital investment plan, to look at where the priorities for investment are. And this is the sort of area that will help steer where we feel the opportunities are, especially when undoubtedly investment is scarce. I think the final point, if I may, is, and again, we've hinted at it, local authorities, NHS organisations and others, we have got a lot of immediate priorities. There's a lot of immediate focus, whether that be on finance, urgent care, reduction in waiting lists and other things. And they will take a lot of time and effort from a lot of people. But this is a sphere of work which is also just as vital. and I think the point around sharing, which colleagues have made, and Claire and I will take that back certainly from an ICB to look at joint development sessions. I think that's something which I'm sure Chair of the ICB and others will be interested in. This is the opportunity to make sure that we share this scope of work alongside the immediate priorities and make sure that it sits alongside.
Yeah,
thanks, Chair.
Definitely. Thank you, Nigel. That's very helpful. I have, not that I can see. Ben.
Thank you, Chair. Just a really quick practical question, if I may. With regard the MEC training model, what is the plan for the rollout of that, and will that be accessible to partners? Because in parallel at MPFT, we do promote MEC and make use of online training resources, but there's no face-to-face provision, which is a bit of a weakness.
Yeah, thanks, Ben. Yes, it will, and I mean, it will look to complement MEC, because MEC is still there in its own right, and there's plenty of online training materials, and it's all good stuff. I think this will look to complement it and look at kind of that Shropshire approach, recognising all the assets of both organisations, human and physical, that we've got in the county. So, and yes, it will be available for the system. It is something that our organisational development in Shropshire Council is looking at working with the ICB on. So, but I think if MPFT are keen to be part of the development of that, Ben, if you or a colleague would want to then that would be great. We're really open to anyone being part of developing it. What we're doing at the moment is taking what was developed for the Shaping Places, which was specifically around the cost of living, understanding that material, and then thinking, how can we take that approach to apply for health and care, as an example, as well as cost of living.
Yeah, that sounds great, and keep in touch. I'd be keen to support that, or perhaps a colleague who works on MEC could do that. As you might be aware, we've been trying to promote MEC also through the sort of digital patient portal that we have, Patients Know Best, as well, so placing resources on there. It's just another avenue to kind of reach patients. I think it's that multi-pronged approach which is important, really, to delivering those messages and catching people at the right time.
Yeah, absolutely.
Thank you. Who else have I got? Can't see. No, it was just you, Rachel.
I was just going to make a final comment if I can. One, just to pick up in the chat, Mark has put in that he's happy to support, and particularly assist and act sounds like something they could be part of. So I think just to draw that and make the connection. And I guess my other comment was linking back to bringing this back to a future meeting in the near future. I think links to the comment around outcomes and impact that Laura and others have made, that we can bring a demonstration of that through to this meeting. I think that in that paper that would be very helpful, because that is all being collated. So I think it's just been very visible in some of the packs. But my other point linked to that, Nigel, was based on your comment, maybe this is something we could be bolder about as a health and wellbeing board. And actually, do we want to not only just locally publicise the work we're doing, but actually write to colleagues further afield about the work that we're doing, and promote actually how we're delivering some of this with some of the outcomes and the plan that we've got.
Who did you have in mind specifically?
Whether we do want to write to the Secretary of State, or whether we want to local members to share with them the work we're doing. I think we need to be telling everybody. I think it's part of the comms plan. From our communities need to understand it, but also we aren't brave enough often to share outside of Shropshire just what we do.
No,
I think this is
this is turning, really shaping into something very exciting, and I agree with you. I think we should share it further afield. Maybe we could add an extra recommendation to the three we have here, which are that the board notes. Sorry, I might put that on. That the board note and comment on the progress of SHIP in 2023-24. Approve the SHIP strategic. Hang on, wait a minute. Is that right? Yes. And note and comment on the system descriptor pack for local care. I'm just wondering whether we ought to add another one to that, to say that we need to set up a comms. Sorry, brain gone. really a comms plan to promote this more widely amongst colleagues, not just our own colleagues, but also further afield. Yeah, can we do that? I think we need to, and I would like to see this coming back as soon as you think you can bring it back, really, because I think we need to keep this moving all the time. It's fantastic stuff. So if you feel that the next meeting is too soon, we'll make it the meeting after that. But I think it needs to come back quite quickly.
Thank you.
Good. Excellent stuff. Well done, everybody. Right, we now move on to the primary care update. Nicola, can you do that from the screen?
Good morning. Hi, I'm hoping that you've got the presentation there.
Yes, we have, yeah. I have a copy of it if she wants me to share, Chair.
Do you want to share? Would you like?
Please, if you could, that'd be brilliant. Thanks.
I think this is the right presentation, but we'll see.
Apologies, it's got the wrong title on, but it is the correct presentation. Yeah, so we'll asked to come and talk about primary care. Probably not as much on people's radar is that primary care is more than just going to see your general practitioner. It also includes our community pharmacy services, optometry and dentistry. And from 2023, the ICB became responsible for the commissioning of pharmacy, optometry and dentistry, as well as general practice. Could we just move through the slides? So although I'm going to, at the beginning, talk about primary care and what most of us think about as primary care, going to see your local doctor, I wanted to focus a little bit more on the other areas that we're also now responsible for. So around some of the things that we've got going on in community pharmacy, in optometry, but also around dental, because there is an issue with people being able to see a dentist when they need care for themselves and for their families. And we're doing quite a lot of work around trying to ensure that people have better access to a dentist. So in May last year, in response to feedback from the public, there was a national programme launched to improve access for people getting an appointment with the doctor. We're now into the second year of the programme around that, and it was about the way that practices can work differently so that people can get in to see the doctor when they need to. And we've done quite a bit of work. So I just wanted to run through that a little bit. In the last year, we've also moved from having 51 practices to having 50 practices, by 2 practices merging together to become one. And we've also had one of our PCNs split to become 2 PCNs. So we've moved from 51 practices to 50 and 8 PCNs to 9. Can we move the slide on, please? We had a number of targets to achieve, and we did a review at the end of the year, and all of our PCNs achieved the targets, and we're now building on that as we move into the second year to continue to work on those, but also refocus and think about some of the things that came out during the first year that we wanted to put additional focus and effort into. Can we change the slide, please? Through COVID, we moved to, as we did with all other services, people being seen more remotely rather than face-to-face. In Shropshire, we do actually see 7 out of 10 people face-to-face in the practice. So although we are improving in online access for patients, use of the NHS app and remote consultation, we do still see the majority of patients in practice as face-to-face. Next slide, please. We were seeing 2.9 million appointments. We have a target now of 3.1.5, and we are working towards achieving that. We're seeing more people month on month as we go through the year. Next slide, please. So, programme that's referred to here as PCAR, the Primary Care Access and Recovery Plan, was based around 4 pillars. So it's about empowering patients. So doing a lot of work, a lot of stuff in the media, a lot of stuff with the public is about empowering patients so that they can use all of the different ways to access GP services, so online consultations, using the app, etc. So that the first point of call isn't always people picking up the phone and ringing the doctor trying to get an appointment. Alongside that, we've had a number of new roles in primary care called the R's roles. So it's an additional team of people. We now have 20 other different skill sets, 20 other different roles working in primary care. So we have pharmacists, we have physiotherapists, we have different nurses, advanced nurse practitioners, etc., so that people can see the person who's right for them. Alongside that, we're trying to reduce bureaucracy. So that's not only in practices, but also reducing bureaucracy and making it easier for the interaction wherever people are in the NHS, whether it's seeing the doctor, whether it's in hospital or other services, so that that's much smoother and making it easier, not only for patients, but easier for practices so that it frees up time for people to see patients. Next slide, please. So this is, I was talking about the additional roles. So in STW, we now have over 20 roles, and that's 253 equivalent people. It's over 300 actual people working in practices. Next slide, please. There is a huge national programme around working in reducing inequalities, and if we move on to the next slide, there's some of the things that we're looking at locally. So we're looking at adults and young people's services. We have a group that's working, we have an executive lead that's working on our inequalities agenda, and we are much more focusing around our addressing inequalities in everything we do in the way that we plan services, not just an evaluation at the end of something after we've already planned services. Next slide, please. Next slide, please. So these are the requirements for this, as I said, the second year of the Primary Care Access Recovery Programme. Next slide. So this year, it's much simpler than it was last year. It was a huge new programme last year, and we had an awful long list of 17 targets to achieve. This year, they've simplified it, and Amanda Doyle, the National CMO, has said she wants it to be much easier so that we're really focusing on the things that will make the most difference for patients. So we're looking at our telephony systems. So this means that when patients ring up, they know straight away where they are in the queue. There's been a huge investment in improving digital telephony so that practices can better manage the demand. At 8 o'clock in the morning, it's still the same. We have everybody ringing and trying to get in that day. And the telephony systems that we've implemented are allowing practices better ways to be able to manage that. An example being, you ring up and they say that you're number 6 in the queue. You can press a button on your phone. It will record where you are in the queue. You can put your phone down, and then the practice will call you back, and you still keep your place in the queue, enabling people to carry on with whatever they were doing and still be able to speak to somebody. We are promoting our online requests, use of the app, etc. However, we do always need to maintain that if people aren't au fait with technology, if they don't have a mobile phone, if they don't want to do that, that we still enable access from somebody walking through the front door, just using a phone in the traditional way, so that we've got the balance of both. And it is a requirement that practices will still have very traditional methods of being able to go and see your doctor. Faster care and navigation. All of our practices have something now called care navigation, so that when you ring the practice, you will speak to somebody who will direct you to the most appropriate place for you to see someone. So it may be that you don't need to see a doctor. It may be that it's a social care need. It may be that it's something to do with a prescription. It may be that it's a physio requirement, or you may need to speak to a nurse, and they will ensure that you get to the right place in the quickest way that you can without it all automatically always going through a GP. Next slide, please. Yeah, so there's lots of stuff in this presentation that I'm not going to go into, but I'm hoping that if you do get a little bit of time, you'll be able to go into those. So that's just the link into the letter from Amanda Doyle that sets out the plan for primary care for this year. Next slide, please. So at the end of the year, we did our end of year reviews. We looked at the things that practice had done really well, and then we looked at some of the things where we thought maybe things could be a little bit better or a little bit different. And we are now going out visiting our practices and PCNs to look at how we can plan together, working on the things that were done last year and the things that we think we could do this year that will continue to build on the improvements that were made. Next slide, please. So I'm not going to go through these, but these are some of the really interesting case studies from our PCNs in Shropshire of the things that they did as part of last year's plan and the improvements that they made for patients. So if we can just go through all of the next slides that are case studies, if we keep going, and then. So there's lots of different things around there about different appointment systems, about text messaging, the Winter Illness Centre in Shrewsbury that was a drop-in on the day centre. We're looking at how we can expand that this year, potentially across the county. Just keep going. So, pharmacy. Something that we don't always think about as being part of primary care, but it is very much one of the 4 pillars of primary care. It's probably the first place that most of us go to when we're not feeling well. Rather than ring your doctor, pop into your local pharmacy and get some advice. At the end of February, there was a national scheme launched called Pharmacy First. And this is a scheme that enables pharmacists to prescribe medication, if required, for 7 common conditions for both adults and children. So we have all of our 182 community pharmacies signed up. We were the only ICB in the Midlands to have every single pharmacy sign up, and that's been running since. We at the same time, there's a couple of other schemes that we're trying to promote more. Is you can go in and get your blood pressure done in the pharmacist, and if required, they will then do a referral directly into your GP service and transfer your results so that the GP can then pick up if there is a requirement for any ongoing treatment. And also you can now instigate oral contraception through your GP service. So next slide, please. So these are some of the figures. So it started in February, and as I say, we were quick on the uptake. All our pharmacists signed up, and that is, as you can see, improving month on month. So in May, over 4,000 people went to the pharmacy directly, had a consultation with a qualified pharmacist, and that then is recorded and then goes into your GP record so that the GP is aware of everything that is happening. We are again above the national average in the uptake of the scheme, and I'm sure that that's just going to keep increasing as public awareness increases that service is available. The figures are there again around the oral contraception and blood pressure checks. Next slide, please. So optometry. This is something that's quite new to us as an ICB and something that has always been managed outside of the ICB, but there's 2 schemes that I particularly wanted to draw to your attention. Next slide, please. So next slide. So the electronic eye referral scheme. There was a review done, and it showed that there was a massive variation across the Midlands and across ICBs within the Midlands around eye care. So there was a national scheme, and we were the first area to launch the scheme about electronic referral into optometry services. Surprisingly, it's the specialism that has the most outpatient appointments from above anything else, which surprised me Next slide, please. So it's a digital platform that anybody can use. It's across private providers, it's across NHS providers, primary and secondary care. It's a service that was commissioned by NHS England, and it covers 11 ICBs. We were, as I say, one of the early adopters, and we were the first to go live. It's been a big project team that's worked across all of our providers, and it's now been implemented. Next slide, please. It's quite a complicated down. This is just the pathway about how people get referred into the service. Next slide, please. So we started last year in February. We signed up. We then did all of the mapping, testing. Through into the middle of next year, we did all of our things around RIG, and the very first referral was sent in November. So as of last month, we've done more than 5,500 referrals, and 87% of our providers are now signed up. That's one of our targets now, is that we get all of our providers signed up, and we're in the process of trying to achieve that. Next slide, please. So why did we set it up? It's more efficient. It's easier for the patient. It reduces delays. In our practices, it reduces the work for our GP practices, reduces the admin, it reduces duplication, and it reduces the risk of losing referrals. For the optometrist, it's easy, it's standardised, and the system allows them to share images much more. And then when we go in specialist services, it's much easier, better flow of information right across the system. We're using standardised advice and guidance, and it's simplified the whole pathway. Next slide, please. So the challenges, we did face some challenges around our information governance, our IT processes. As with always, we don't always have all of the same systems. So there was some work required to do that. We're still working on that, obviously, as we bring the rest of our partners on board. And there were some issues around sharing information across providers, particularly in the independent sector. Next slide, please. So in our optometry team in the ICB, they've been working again across all of our providers to develop a training resource that is for use not only in health services, across social care, across any providers, around supporting people with sight loss. So just a little quick run through of the work that they've done and what this is, and then obviously these links are available to share, because we want to get this training out as far and wide as we can so that it's used. Thank you. Next slide, please. So it's an e-resource. It's available for people working in health and care. It was developed because there was an awareness that it wasn't something that people were always conscious of in the day-to-day work, but through this training, it increases awareness of the things that we don't always consider, and there's some of the things that we can do quite easily to make it much easier for people who do have sight loss. So next slide, please. So again, the journey, this has been a longer project, started over 2 years ago, and the group got together. They worked together, including experts, patients with sight loss, and then worked through the process to determine what it was that we wanted to do, how we would develop it, and then how we would roll it out. So there, as you can see, it's gone through optical practices, through the eye screening, through all of our partners, through the council, etc. Next slide, please. So these were our group that came together and worked with us to ensure that what we were doing was the right thing and that it would deliver the aims that we wanted. Next slide, please. So the training, there's 2 modules in the training. You can do, they both stand alone, they're both worthwhile doing. The first one is more of a starter module, but you could do the second one if you wanted to. The second is more in depth, and it's helping people to understand how we can help people with sight loss navigate their way through our services and systems. Next slide, please. Just some feedback there about how useful people have found it having done the training. Next slide, please. Next slide. Thank you. So this is in the pack, QR code that you can scan. If you can get that out there to all of the people that you work with so that people can access this training, and it's something that you can do whenever you've got time to fit it in. Thank you. Next slide, please. So as I said at the beginning, dental, not something we always consider, but you probably know yourselves, if you've got toothache, there's nothing worse. Access to dentists is a problem right across the country, not just in our county. And it has been the focus of government campaigns for a number of years, but we still do have issues in people being able to get access to an NHS dentist. Next slide, please. In the last 6 months, we have the Director of Dental Public Health has conducted an equity audit in STW around how easy it is for people to access a dentist, and a report's been produced. It is, I think, in the pack. If we carry on, it told us, well, one, it confirmed some of the things that we already knew, but it also gave us a focus for where we need to be thinking about where are the worst areas where people struggle to get a dentist, and how can we commission services differently to try and address some of those gaps that we have. So just a bit there, an equity audit is around how fairly dental services are available, balanced against where we have the biggest demand for dentistry and oral health care. Next slide, please. It was done with information from our dental advice line, with Health Watch, feedback from the public. We also looked at housing developments, where we've got current housing developments, where there are planned housing developments, so that we can anticipate where need may be as we move forward. Next slide, please. So it was done from oral health data from a couple of years ago. There's a programme that looks at the dental health of all 5-year-old children in the country. That's an ongoing audit, so information was brought from that. So generally, our dental health is relatively good compared to both the West Midlands average and that for England. So our figure is 17% of 5-year-old children will have experienced some dental decay. The West Mids is 23.8, England 23.7. So it sounds like everything's good, that we're doing really well. However, when you look at the differences across the area, in some areas where we've got the highest deprivation, 35% of children at the age of 5 have dental decay. So we're way above the national average. And this audit's identified that to enable us to say, what can we do to make sure that we even out some of those figures so that we've got better provision across the area. Next slide, please. Next slide, please. Again, they're talking about inequalities and the fact that in certain ethnic minority groups, dental decay is higher. So over the last year, we dentistry is commissioned in what they call units of dental activity. So each interaction with a dentist is a unit of dental activity, and that's how the service is commissioned. Over the last year, we had a large number of units of dental activity given back to us, where dentists said either they were stopping delivering services or they were unable to deliver the amount of services that we'd commissioned from them. So we were given back a lot of activity that was unable to be delivered. So using this dental equity audit, we are planning of how can we best commission dental services with all this activity that we've been given back to address the inequalities that we've got. Next slide, please. So priority areas have been identified. They're listed there. They've been grouped together to make them viable contracts for dentists to bid for. And we're about to start a procurement process to commission dental services in these 7 areas to address some of the inequalities that we've got at the moment. Thank you. Can we go on to the next slide, please?
That's the end of the pack.
Okay, sorry. Thanks. Yeah. So any questions, please? I know there's an awful lot of information in there, and I'm happy to pick up any questions outside the meeting. But I thought it was interesting to look at some of the other areas of primary care, opposed to just general practice as we normally do.
Nicola, thank you very much. That was a comprehensive report, and it is, you're quite right, it's very useful to have dental and optometry added on as well, because particularly with regard to dental, we've all been aware that there have been problems in that area. And I was interested to see that my own division comes under one of the problem areas, which is interesting because, as I endlessly tell people, it's a very rural area. And I suspect that one of the reasons that it's on your list, on your hit list, as it were, is due to problems of access to a dentist as much as anything else. And on that, I'm just wondering about whether access to dentists, is improving, because it has been such a problem right around the country. And I think it's probably not been quite so acute in the south of the county, but certainly it is a problem elsewhere. So could you just comment on that?
Yeah, so we've been trying to improve access to dentistry to pre-pandemic levels, and we are improving. We're not quite there yet, but we are improving, and it is something that we're measuring and monitoring really carefully. Hopefully, when we commission the new services and we are able to deliver services and spend the budget that we've got. It's very unusual that we have some money that we're not spending. It's usually the other way around. We'll be able to improve access even further and increase the levels to better than it was before the pandemic.
Thank you. Any other question? Do you have? Rachel.
Thank you. And I think it is really useful to have the comprehensive update. So thank you very much. I guess just on the primary care, it would be really helpful just to understand if there's any variation in primary care. I know you said the targets were achieved in terms of the recovery plan last year. Is there a significant variation in any areas, and is there any inequality? I mean, that might be other information that you can send. I think on pharmacies, I was just thinking back to our last item, is pharmacies are brilliant hubs in our communities. So, and as a health and wellbeing board, we've obviously got a duty around the pharmacy needs assessment. I think we've got quite ambitious. We're very ambitious about what more we could do with pharmacies. I guess, is there an opportunity there for us to do a lot more, linking together with pharmacies, and building on that? And then I think my final bit was just around the dental. Just in terms of the dental, we have talked about that here at this board a number of times. I think the suggestion was, because there's an awful lot we could talk around dental, isn't there? And we have to talk about some of the health promotion work today that would be fundamental, getting into those communities earlier, linking again to some of the family hubs and how we promote those messages, and then through to the dental services that we commission, and obviously the hospital, the impact. So I wondered if that was something we'd talk about picking up at a development session, because I think Telford and Wrekin are interested in that too, in terms of the ICB, and then bringing something back to a future board. I think particularly for me, the inequalities is interesting, because I did talk to colleagues about falling apart here, how it's difficult to get some of the smaller detail for some of our local areas, because the numbers are very small in Shropshire when you get down to some of those numbers, particularly on children's dental health. So is there other data that we can layer on, so that when the services, we're putting those services in, when we're doing some of the health promotion work, we can get a bit more nuanced within that. So I think that's something we can support with, but I think I'd welcome that broader conversation around dental, because it's such a important topic, isn't it? And what more we can all do to support. So just the comments in those couple of areas from myself, if that's okay.
Thank you very much, Rachel. Penny.
Thanks. Yeah, and just to say, I think there's a lot more we can do with community pharmacy around the community hubs, as you say, Rachel. But we are working with them, in particular with the women health and wellbeing hub part as well. So that is happening. But I do think there's more we could do. And the other thing, Nicola, that I just wanted to mention, I've just sent you a report on a grant that the community resource received from us for sight loss and hearing impairment, just for you to note the work that goes on in the voluntary and community sector. So they host 3 peer support networks around the county. So I was just thinking about that training around sight loss, and is that available and has it been promoted in the voluntary and community sector, because they do a lot of work in that space. So I just wanted to highlight that one.
Great, thanks, Penny.
Great, Claire. And then Laura.
I was just going to talk about the dental prevention for children and how we do that, but Rachel's obviously picked that up. I think we need to think about how we could do that differently. So it feels to me like it's wider than just the dental profession. It's education, it's health visiting. I know there's simple things like brushing. Are we absolutely sure, for instance, that sugar-free products are being sold, prescribed from a medicines point of view? So I know that's something that dental public health consultants are really keen on. And then there's sort of the snacking messages and things like that. So I think talking about the first piece of work around the integrated work that we do, how can we incorporate some of that work, that information, that communication through our hubs, our children and family hubs and that sort of thing. So
yes, good point. Thanks very much, Claire. Laura, did you have?
Just really thanks again, Nicola. It's really comprehensive and detailed presentation. Actually, a lot of information in there. But just picking up, I think on Rachel, your point around that wider look in terms of equalities and people accessing dentistry, for example. I think we really just need to pick up kind of the vulnerable adult side of that as well. And assure ourselves that we're doing a work around that, particularly for those with learning disability and autism, because we know some of the complexities of people accessing dentistry, but also our older persons as well. Not just the care homes, but those in other environments of supported living, etc. So it'd be good to try and understand what activities and actions are going on that support those kind of cohorts, as well as obviously the children and young people. I'm sure there is. It's just making sure maybe we're picking up on that as well as part of that wider piece of work.
Nicola, do you want to come back?
Yeah. Can we link up after the meeting and get together, because obviously keen to use whatever we've got already and build on things that have happened before. Yeah, so that's brilliant. Thanks.
Okay. Any more questions? Can't see any. Can you see anything? No. Okay. Thank you very much for that very comprehensive report, Nicola. It was very helpful. And as I say, it was excellent to have added optometry and dental onto that as well. That was great. The recommendations that we're asked to approve is that basically that we note the contents of the update and appendices. So I don't think there's any problem about that. And we now move on to reports for approval of recommendations with discussions only by exception. Under that comes the Better Care Fund. And Laura, please.
Thanks, Chair. And I do feel inadequate because after these lovely presentations and slides, I don't have one, but I'm hoping that the board have read the report. So as we've been here many times, as you will be aware, that the Better Care Fund, in terms of its governance and formal approval, has to come through the Health and Wellbeing Board. So today what we're doing is presenting 2 reports, both a summary of the BCF end of year plan for 23-24 and the BCF annual plan for 24-25, which has been submitted as per deadline. So whilst it's already been submitted, we which does happen in terms of timescales and time frame, we've still got the requirement for it to be formally signed off here. So the appendices that you've got there may be subject to change because it's literally going through the assurance process as we speak, and so it may slightly change depending upon if they come back with anything to change. I don't intend to go through the report, but I think it's just important to say that this is part of a 2-year plan. So this is the second year, we're going into the second year of a 2-year plan. We haven't had any informational detail about what next year's plan will look like, whether it's going to be back to an annual plan or to another 2-year plan, depending upon, obviously, with a different government coming in, they may have a different view of this. So we're awaiting that. In the meantime, though, we are pulling together, and I've made a reference to it in the report, 2 workshops to have a look at the Better Care Fund in terms of ensuring that we having a review of what we're doing as a system, because things have changed. So the Better Care Fund historically hasn't changed in terms of what we've inputted as a system into it. The concept and what we're trying to do is not changed, so we don't think it probably will. I think, Nigel, you referred earlier on in terms of some of the priority areas. Prevention will be a key area, we think will certainly be there. So as a system, things have changed, so what are we doing around that, and what do we want to include potentially in future BCF plans? Support with discharge and admission avoidance we think is probably likely to continue. Therefore, the activities and actions that we're doing as a system, we'll need to make sure that they're embedded as part of that. But I think it really offers us an opportunity now to review this as a system, to look at, okay, if we wanted those, the aims and the objectives as a system for the Health and Wellbeing Board, for SHIP, etc., for the ICB, what is it that we want to do moving forward to put into that? So it just gives us a bit of time to reflect on some of the work that we've done and some of the work that we want to do in the future. So those sessions one will be in August and one in September. So hopefully some invites have gone out. If you are interested in attending, please obviously contact me. In terms of metrics, we're doing really well. I think one of the areas just to highlight is we had to do a demand and capacity piece of work. So this year we've worked with the system around what we're trying to do, particularly around discharge pathways. So we're fundamentally a system trying to increase the percentages that are going through pathway 1, pathway 2, and reduce those that are going through pathway 3, which is into care homes. So the idea is that the system in itself is really supporting getting people home first from hospital, and reducing that length of stay in hospital, which is a really key factor for us. So just to point that's the demand and capacity work has been done as a system, aligned to what we're expecting and wanting to do moving forward. So there's a lot of activity going around that's supporting those areas of work. And we're looking at obviously the wider support that we're trying to put in place to increase performance, to increase capacity, such as our in-house bereavement support service. So we've got real high performance numbers that we're pushing through our start bereavement teams moving forward. So it's there, as I said, hopefully you've read the report, you would have seen the appendices. They're subject to potential change depending upon what comes back as part of that assurance process. This year's report is part of the 2-year plan, so there wasn't going to be huge changes anyway. We weren't asked, and we didn't need to formulate to put in a really detailed overview report like we do when we submit the 2-year plan. So whilst it is a detailed piece of work, it's not as detailed as the 2-year plan that went in as part of the original submission. And so I'm just asking the board just to approve those 2 appendices. That is it, Chair. Really, back to questions.
Great, that's great. Thanks very much, Laura. It is a good report, and it is a full report. And we'll have to wait and see what shape the future Better Care Fund looks like. So we just don't know at the moment. Does anybody have any questions or comments for Laura? No, you've done an excellent piece of work, Laura. And nobody wants to ask anything.
Oh, no, that's fine. Just to point out again, I think I just raised it, but I think once Penny was presenting it, I think whilst we don't know what's happening with the future, we are still working at pace on the preventative side and the contracts and the focus around that kind of front door and the offer to our community and our residents across Shropshire. So that work is happening as we speak. We're progressing that. We were at the strategic board for the ICB strategic commissioning board the other day. We had a conversation around, didn't we? I think Nigel was in the room and certainly Claire, around that preventative agenda and the fact that as a system we're going to have to start taking risks and looking at that longer term contracts and that commissioning and framework approach, particularly around some of these. So we're not stopping and waiting. I think we're going to have to progress that. And I just wanted to make that comment, and it really does align to the work that Penny presented earlier on, and making sure that, you know, we are commissioning aligned to our strategies across the system.
Nigel.
Yeah, I think Laura makes a good point actually, and building from, and not necessarily specific about BCF. But Rachel also talked about that alignment. Rachel and counterpart in Telford and Wrekin, also part of the ICB Strategic Commissioning Committee. It's really useful. Claire and I are part of that, as is Laura. I think there's an opportunity because today's board has been a really useful snapshot of the set of work. We've got a couple of other things coming as well, giving us the strategic and the overall planning landscape, as well as the evidence of real stuff that's going on. You know, Nicola described it, obviously Penny and others. So with that, we've got a lot of information that we can see, and I think it's the both health and wellbeing boards alongside the strategic commissioning committee. I think we've got a sort of collective job just to make sure that we're coordinating that, and we are. And the evidence, you know, we've got, you know, Penny, myself, Laura, all in joint roles. People like myself and Rachel with Claire, we talk all the time, because that's the nature of trying to make sure that we keep doing this in a coordinated way. So that's I think, and we're probably still early days, but there's it's way more than green shoots that we've got in terms of this evidence, but plenty more to do. And the point I think Laura's then making is that this is the sort of evidence, and it goes back to what Rachel and others are saying. We now need to promote and share this widely, because then the momentum will build. And I think you said that as well, Jen. Thank you.
Rachel, thank you very much for that, Nigel. Very helpful.
Yeah, and it was just to build on the point and that those conversations around, I think, Laura, you've made around the prevention part of this, and that was the conversation we got into, is how we are doing some good work. I think Claire, you said we've done a lot of what we've done without additional resource, but there does need to be resource that goes into this. It does need to get this moving at pace, to really start to change and turn the dial. That pivot to prevention that was talked about and has been talked about nationally and locally. And I think that's going to be the critical bit for us going forward next year. We can't keep doing this without starting to shift that investment. How do we challenge ourselves? We said that when we put the prevention strategy together. We need to be able to track this and monitor it. We are seeing some of that, but you flagged it in the paper rightly, Laura, some risks here. We've talked about the voluntary sector and the need to share that investment. We know that that's a risk. We've talked about it here at this board, and I think we do need an update on that at some point. How can we really come together as a system and start to shift some of this? And I guess particularly if we go into the next rounds of commissioning, funding, that's something we need to keep talking about. And I think we're flagging all the good work we're doing, but we also need to flag the real risks and gaps around this, and be given that flexibility to shift some of that investment. Yeah. So I just want to highlight that bit in the paper, and it kind of, as Nigel said, it all does link together.
Yeah, I have to say that I entirely agree with you, Rachel, and I think it would be nothing short of a tragedy if we were unable to continue to grow what we're doing, because there wasn't the realisation that we need to make the shift in resources. And, you know, everybody gets a bit shy when we have to talk about resources and where's the money coming from and all that. But actually, if we need to agree that this is the way forward, because we've got to relieve the pressure on our acute sector, apart from anything else. And in order to do that, we have to talk resources. So I don't think we should be shy about it, really. Thanks all. That was very useful. Thank you very much, Laura, for that. So we note the contents. We approve the Better Care Fund end of year report 2023-2024 and the annual plan 2024-25 and in appendices 1 and 2. Everybody happy with that? Yeah, good. Okay. Right. Jess, I see you're up and ready.
Morning.
Morning. So we'll move over to you for the JSNA update. Thank you.
Cool. So good morning, everybody. So we've provided the usual update for JSNA work programme, which covers our place plan JSNA programme of work, the web-based needs assessment development, and then our thematic JSNAs, including the PNA. So that's our pharmaceutical needs assessment. I won't go through the whole report. It's just we're asking the board to note contents and timelines. Place plan JSNA progress, we're ambitions to publish all 18 areas by autumn this year. 7 of those areas are published on the website already, and the remaining wave 2 areas are underway. We've got Church Stretton, Craven Arms, Cleobury, Mortimer and Bridgnorth profiles to be showcased at stakeholder events in September, and then the remaining surveys will be launched, or have been launched, sorry, and undergo analysis in due course. So work's going well there, and it is a huge effort from the team, so very much well done to them. The web-based needs assessment development, these are the Power BI dashboards that are on the website under JSNA. They're interactive tools that will be aligned to each of our JSNAs that are those standard, usual, traditional reports. We are updating the children and young people Power BI dashboards at the moment to reflect what is in the thematic report. The children and young people JSNA thematic report, which is split into 5 chapters, which we brought 2 of them last Health and Wellbeing Board, are still being worked on. We've got maternity, school-age children and young people almost there and almost finished, and we aim to bring all 5 chapters to the board in September for endorsement of recommendations and sign-off. They will be going to their relevant boards and partnership meetings beforehand as well, before we come back to the board. Lastly, the PNA, so pharmaceutical needs assessment, is due for a refresh in 2025. Time is just flowing so quickly. And the working group will reconvene in January of 25, so with the view to publish by September 2025. So that's it from the JSNA update. If you have any questions.
Anybody? Yes, Penny.
Just to say, because we didn't go into it in detail in the presentation or in the report around the development of the community and family hubs and the integration work, but the place-based JSNAs are a corner, really give us the launch pad for that work, and they tell us where we need to be and where the inequalities are in particular, and where the focus should be in the different areas. So it's been really helpful, and it has given that launch pad for a number of quite big pieces of work, such as the work in Highly and others. So they're fantastic.
Yeah.
It's really helpful.
No, I quite agree that it's a really brilliant work. So thank you very much indeed. Jess, any more questions? Laura?
Yeah, just a quick question, Jess. So you've got in the report a commencement of the mental health needs assessment. Is that
yes.
Is that all scoped out already? I'm just wondering if there's
not yet. There's a meeting. Gordon Coshane's setting up a steering group for that one. I think it's in August, so that's when work will start. So it will top and tail with the CYP JSNA finishing and that one starting. So if you'd like to be involved, I can definitely get you on that list.
Yeah, me or one of the commissioners, that'd be great, Jess. I'll maybe catch up with you after, because that's a really important piece of work that I think we would really, want to inform some of the strategy work we're doing.
Sure, I haven't seen the list of who is on the steering group yet, because Gordon's leading on that, but I will speak to him and check.
Brilliant, thank you.
Great. Rachel?
Yeah, I was just going to flag, because obviously the JSNA dovetails into our the population health management approach, the data approach we're taking across the whole system. Mental health was the next one that was identified. We've done pockets of work, we've done very good audits on parts of some of the services, and the JSNA approach across the system aims to bring that together into, so you've got some of that data, you've got some of the qualitative information, so we do need everybody to input into that. And I guess it's just a reminder and a place that how we use, we need to keep building up these JSNAs to reflect the information that we need at both thematic and the place-based, so that we start to draw, as we conclude all the place-based JSNAs, we start to draw some of those themes out that we need to be looking at across the system, as well as obviously what we need to be doing within place. And it's, I think, Nigel, you said how we link it to the estates work, how we link it should be informing different programmes. We've long lobbied as a board that the JSNA isn't just about health and wellbeing. It's actually much more than that, because that everything impacts our health and wellbeing. So I think this is starting to move us towards that with the web tools, with everything. So I think as a board, it's just keeping promoting that to colleagues, and that we don't, and how we keep adding value to the work. So we've got cost of living dashboards that looks much broader than just the work, the health and wellbeing. We constantly the teams keep bringing that back together. So they're really rich. Again, it's something else we just need to promote.
Yeah, absolutely.
Value too.
Yes. Yes, and I would just comment actually the promotion of a lot of our work. We really should be paying rather more attention to, I think, because we are making a lot of progress, and I think people should know more about it than they do. So, it all goes back to putting together a comms strategy, I think. So, can we think about doing that? We certainly can.
Yeah, we do. We've got a comms link. Maria helps it is our key link, so we can. I can pick that up with Louisa, and Penny will pick that up.
Yeah.
Maria.
Because I'd like to see more made of the very hard work that's going on. Excellent. Thank you so much. That was very helpful. Thanks. And we have there a recommendation that we just note the update to the work programme and timescales. So that's great. Thank you, Jess. And now we get on to Claire and the joint forward plan, please.
Thank you, Chair. This has kind of got delayed because of the pre-election period and the general election. But last July, we published our first 5-year joint forward plan. And this is the refresh of that plan. So a progress report on some of the actions that have been completed. Now, many of those are over the last 12 months have really been around steering groups and governance and that sort of thing. And we had a discussion about the plan at the last ICP meeting, and we really want to start and see the impacts that this is having. And I think some of we need, again, Chair, you talked about bringing everything together. We are starting to see that, but I don't think we're necessarily linking it back into the joint forward plan. So we'll take that, because Nigel and I will be looking after this piece of work for this year. So the progress and the operating model at the ICB are now working too. So we've also had our restructure, hence why I've got a new job title and Nigel's got the joint role as well. But actually thinking about how we deliver the joint forward plan, so the 3 areas around person-centred, local care, and then the hospital transformation work, and then all the other enablers that sit around that. And then our approach to commissioning intentions. So how we work with provider collaboratives, how we work through place, what our priorities are. So there are still some pieces of work to do around that. And then also we've just done some clarifications around the big health and wellbeing conversation that you said we did piece of work, patient choice, some of the workforce and the financial sustainability elements have been updated to reflect the next sort of 5 years on a rolling basis. So I'm not going to say any more than that. Part of the process of publication is bringing it to the Health and Wellbeing Board. I hope that this board has felt that it's been included in discussions around it. Certainly we took it to Joint HOSC and just need to reflect, although the NHS, we have to publish it for NHS England, it is a partnership approach. We can't do the neighbourhood, the local care work without working with our other partners. And they were very much involved in the writing of the document in the first place. So it's really here for your oversight and approval.
Great, thank you very much indeed. And once again, it does include all these different strands. And I think what is very important is that it makes clear that there are so many players and everybody's contributing, which is really helpful. That's very good. Does anybody have anything they would like to ask Claire or comment? Rachel?
I guess, just to say, as you said, we have tried to do this in an inclusive way. I think this is the first time we've done it, and we did have the challenge rightly from the ICP about, are we making progress? How do we demonstrate impact? So I think this is iterative as we continue to improve it. We're also, the ICP have also asked for the development of a dashboard as well, linked back to the original outcomes we set ourselves, and that includes all the health and wellbeing board's outcomes. So that work, actually, Jess and colleagues on behalf through the population health management are leading on bringing that together. So we'll have the kind of the sort of qualitative and quantitative information that starts to demonstrate the progress that we're making or not, where we need to focus our attention going forward. Obviously, patients' voice and others from colleagues is really important in that. But just, I think this is the first time that we've had to do this. It's really important that we do capture this, that it is a partnership piece of work, and that we get feedback from others on how we can improve, how we record and monitor that. But the alignment, again, is key. Yes.
Yep, that's great. Thank you very much indeed, Claire. We are asked to receive the report and that the board discusses the changes for 2024-25. Everybody happy with that? Thank you. Now we get to the chair's report. Normally, this is where I read out. Sorry. Thank you. Normally, this is where we read out details of pharmacies that have opened or closed. However, this month this is rather different, and this is really a statement that I would like to make, to the effect that as a health and wellbeing board, we're naturally focused on the best interests of the health and wellbeing of our local communities, which lies at the very heart of what we do. And we are therefore mindful of the recent national coverage in Channel 4 dispatches programme on the Royal Shrewsbury Hospital, which came to light following the recent Care and Quality Commission's report published in May on the area's two acute hospitals, the Royal Shrewsbury and Princess Royal in Telford. As a board, we recognise the serious concerns and issues these have raised among our communities, and we want to acknowledge this. And I know the concerns raised following the media attention and the publication of the CQC report will be examined at the next Joint Health Overview Scrutiny Committee, Joint HOSC, where the committee members will meet with our health colleagues to review the challenges and actions required to improve patient care and outcomes. As a board, we will monitor these discussions and will review and support the work undertaken by SAF and as a system to help improve the outcomes for our patients. Thank you. And now reports for information only, the SHIP update. Penny.
Thank you. Yeah, it's in the pack. This report is just a reassurance of the Health and Wellbeing Board to be able to monitor and recognise the continued work of SHIP to deliver the Health and Wellbeing Board priorities and the SHIP strategic plan. So it is in the pack for members to see.
Okay, thank you very much indeed. Before I close the meeting, do we have a date? Does anybody know if we have a date for the next one?
I think it's the 19th of September.
19th of September.
Back to a Thursday.
Right.
And I give my apologies because I will be interrailing around you on that date.
Good for you.
Reclaiming your youth.
Yes, but the whole lot of
Not in hospital.
Scruffy students.
Can we finish the feed now?
I think you may. Yes, thank you very much, Lisa. Right, I'm going to close the meeting and thank you very much, all of you, for your contribution. Although we have not been many in number, I think there's been we've had some very high quality stuff that we've gone through, and I'm really grateful for all your contributions. Thank you so much.